Thank you so much, everyone, and I really appreciate for your kind introduction. Um, it's so nice to see you all tonight, or this morning, your time in Thailand. But before I start, once again, I want to thank everyone who put this great event together tonight, and all the nail crews in Thailand, and also GAO personnels in Korea. Uh, as I was introduced, kindly enough, I'm in a small college town called Iowa City, Iowa, in the United States, where I joined the University of Iowa College of Dentistry last year. I'm teaching dental students here, mostly in clinic. And once again, I'm honored to have this opportunity to talk to you about screw tonight. Let me start my presentation. Today's topic is about screw. What is screw? How's it different from nails? Both go into an object like woods or any metal, but screw works a little different from nails, I guess, because it's got threads on the surface. Um, you can probably take a look at this video clip. Screw is basically a tool that translates the rotational movement into linear movement. So when you rotate a screw, what it does is moves along the long axis of the screw, either moves up or down, depending on how you design the thread. Um, Everyone probably knows what preload is because we heard about it so many times. But let me go through this concept of preload one more time. So just to make sure we are on the same page. So when you rotate or tighten the abutment screw, uh, my cursor does not move. Anyway, so when you rotate or tighten the screw, the clockwise, I mean, the screw will move down into the internal thread of the implant. So it'll bring the abutment and implant together until they meet at the interface or the platform of the implant. Let me go back a little. So if you keep tightening beyond that point, what happens is that it'll only make the inner screw stretches out. So these two objects, abutment and implant, will not come in any closer. But instead, there's a clamping force built up inside the screw because it gets stretched out, which is called preload. So are we on the same page now? I hope we do. So the preload is the tensile force within the screw, and it is the same as the clamping force the screw creates between the implant and the abutment. But let me continue what I was saying, actually. So there's a friction between the abutment screw and the internal threads of the implant. So that friction is what's keeping the screw it in its position so that it doesn't rotate counterclockwise. But if you look at closely again at the this picture, the relationship between these two different threads, the lower part of the abutment screw is not really in contact with the upper part of the internal thread. There we go. So this part is loose. They're not in contact. So let's talk about the opposite of what I just discussed. So how do we lose friction between those two threads? People say external, forces opens up the joint. It opens up the interface and create a little gap between the implant and the abutment. That's probably right, but again, how? What really happens? Let's look at this video clip a little bit. This video clip shows what happens at the interface when the external force is applied. I will discuss the difference between external connection and internal connection a little later. You can see the opening at the interface, don't you? So what happens to screw when the joint opens up like this? It gets even more stretched out, right? Like this. When the joint opens up, the screw gets stretched out even more. So it's in bigger tension. So what about the friction between threads at that point? Increase or decrease? It'll probably increase. The friction will be even bigger. So is it possible for the screw to rotate counterclockwise at this time? Probably not. The screw just won't get loosened because it's in greater tensile force or the clamping force. But what about when the gap closed? What happens to the screw then? It gets shortened, doesn't it? The screw gets shortened and it loses its preload at this time. What about friction? It'll decrease also. So this is pretty much when the screw rotates counterclockwise by losing its friction. Yes, the screw loosening does occur, and it's quite frequent based on these numerous studies. Dr. Goodacre published a real nice review article in 1999 and also 2003. Based on these articles, there are number of screw loosenings that actually occur. And it's been quite a bit of a clinical problem. But let's talk about two main factors that affect screw loosening. First one is overload. During function, the implant encounters so many overloads. These overloads can be pretty much just any force that exceeds the clamping force or the preload of the screw. And these overloads create eccentric movement on the prosthesis. Let's take a closer look. These overloads on one end, as you can see with this red arrow, the overload on one end create cantilever force on the other end, trying to lift up the other end and create a tiny gap. And at the interface, it's blinking now. So you can see the gap created by the cantilever force. And this in turn will increase the preload or the clamping force even bigger because it stretches the screw. So when does the screw get loosened again? When the external force stops and the gap closes again, right? We just discussed that a minute ago. Second thing to consider is the misfit. Misfit refers to the inaccuracies of prosthesis during fabrication, especially any gap at the interface between the implant and the prosthesis. We usually get these misfits during the fabrication process. If there's a misfit or a little gap at the interface between implant platform and the prosthesis or the abutment, this gap tends to exaggerate the cantilever movement and make the screw loosening even easier because there's less resistance to the lateral forces. Let's say you're trying to deliver a multi-unit, 2-unit in this case, splinted implant crown. The splinted structure can pretty much eliminate all the cantilever movements which initiate loosening, like in this prosthesis. 2-unit or multi-unit splinted prosthesis can eliminate cantilever movements. With a misfit though, which is usually created from the prosthetic process, when you tighten the screw, what happens? You're literally bending the frame. When you tighten the screw, you bend the frame like an arrow, you know? So now the misfit or the gap is smaller. It was bigger, but now it's smaller because the frame bent. So this frame is in constant tension. It tries to go back to where it was. So it's in constant tension like an arrow again. So the only force holding it in its position is pretty much the clamping force of the screw itself. And it's constantly trying to rebound. And that'll make the screw in tension, which is called preload again. When you look inside the implant, this is how it looks. The upper parts of the abutment screw engaged into the lower part of the internal threads. Can you see that in the red, yellow square? The upper part of the abutment screw is in contact with the lower part of the internal threads. Because the thread is stretched out, it's pulling up the implant or pulling down the prosthesis. But let's say you close the gap just a little by tightening the screw, right? Because you tighten the screw, it'll bend the frame and it'll come, those abutments will come closer to the platform. But those two interfaces are not still in contact. What happens to the screw when the process is pressed down by the external forces? You lose the friction or the preload between the threads, and the screw will rotate counterclockwise, which we call screw loosening. So when the external force is applied, it'll press the frame down, reducing the tension inside the screw or making the screw lose its preload, and that also makes the screw loses its friction, and then that's how the screw loosening starts. Actually, this lack of passive fit is reported throughout the history of the implant pretty much. And that's probably the one biggest reason we stopped making multiple unit screw retain cast prosthesis and turn around to cement retain prosthesis these days, because we could never solve this non-passive fit from the prosthetic fabrication procedure. There's been always the metal contraction during the cast procedure, so they could not get rid of the gap after casting. So they stopped making any screw retain multi-unit prosthesis. And this is also why we love to use cement retained implant prosthesis these days, because the cement space created between the abutments and the crown on top of them compensates the error from impression or the casting procedure itself. So this is pretty much the only way we can get really passive fit between prosthesis and implant, which is cement retained prosthesis. Let me talk about the difference between external and internal connection a little bit. I'm pretty sure not many of us are still using external connection these days. Usually with internal connection, it usually go in a little deeper into the implants than the external connection being kind of sticking up on the top of the implant. This is just the way they make implants, external connections and internal connections by the manufacturer. Just 1 second. On the left, having the fulcrum point at the end of the platform, as you can see in pink dot, that's the fulcrum point. And there's pretty much this very short, I'm sorry, you can see my cursor. This is pretty much this very short wall trying to resist against the lever movement with external connection. But on the right, with the same fulcrum point at the end of the platform, The lever movement is resisted by this long axis, the long axial wall inside the connection or inside the implant. That's why the internal connection resists much better to lateral forces or any dislodging or cantilever movements. Most external connections are compatible with each other because all of them have pretty much the same structure, which is hexagons sticking up about 0.7 millimeter high, uh, except for BioHorizon though. The third one from the left on top, the green hexagon, which is BioHorizon, which is the height of it is 1.0 instead of 0.7. So it's 3.3 millimeter higher than other external connections. But other than that, most of the external connections are pretty much the same. They're compatible to each other. External hex connection has minimal resistance to tipping forces. So the axial here again is just too low to resist against any lateral forces. So that's why when you try to deliver an abutment in patient's mouth, it tends to kind of come off quite easily. Uh, you have hard time trying to deliver it and try to screw it down with your hands. You know, it just keeps coming off. There's a reason though. There's a thing called rotational misfit, which is basically a structural misfit or freedom created during manufacturing process. This is to make sure it's feeding, because without this gap, intentional gap, the abutment just would not be seated all the way down on the platform of the implant. We need some gap to make sure those two abutments surface and the platform meet together completely. We need some gap. But with internal connection though, there are two different types. One is called parallel joint, butt joint, and the other is called sloping shoulder. Again, we can classify them as friction type and non-friction type. The one on the left is non-friction type because it's got flat platform where the abutment and the top of the platform of the implant meets together, which is basically a butt joint. So to make sure the seating at the interface, you have to have some gap inside. Even though this is an internal connection, there's a gap. But with sloping shoulder, though, it's got friction at the sloping shoulder like this. So because it gives you something called wedging effect, the more you push it down, the more friction you get. So that's why the internal connection has two different types. The one with friction or the other with non-friction. There was a study from a long time ago which revealed internal connection seems to resist much better against lateral forces, which is kind of obvious. In this study, though, they tested 3 external connections and 1 internal connection with lateral force. The internal connection they used in this study happens to be a replace system from Noble Biocare. So when the lateral force was applied, the resistance to the lateral force was biggest with replace, which is an internal connection, basically proving internal is better than external connections in terms of force distribution. So that's pretty much why we nowadays prefer to choose internal connection over external connection. But with internal connection, there's a very unique thing called a settling, or some people call it sinking, because any polished metal surface has some micro roughness at the sloping interface, and which can be found in most internal connection these days. These microsurfaces, micro roughness, gets smoothed out over time, and the interface becomes in closer contact over time, which is called settling or sinking. Why is it a problem? Because what could happen to internal connection, internal friction type connection, is that the abutment can be seated deeper over time as a result of the settling or sinking phenomenon. So what we usually recommend is to tightening the implant once to a 30 to 35 Newton centimeters, and then about 5 to 10 minutes later, we do the second tightening, just to make sure, just to get rid of or to compensate the settling effect, which is a sinking effect, and make sure the abutment is tightened down all the way. What are the consequences of screw loosening then? What happens after screws gets loosened? A lot of things, the screw can be loosened, and then it can fracture inside the implant. Or because of the loss of screw or the fracture of the screw, the prosthesis itself can get dislodged or can be lost even, and the patient can swallow it sometimes, like in this case. If you let the screw loosening, if you just keep watching it doing nothing, then the screw will just come out completely, or it can even fracture. So that will cause the crown dislodgement and the loss of crown. Or sometimes because it's so mobile, it's so loose, during function, during chewing, the crown itself can fracture in half, like in this picture. And sometimes the implant itself can fracture in half, like in this case. What you can see in these implant fracture cases, quite often we see some bone loss around the implant that's probably caused by the screw loosening or the inflammation at the interface, the abutment and implant interface, which will cause the bone loss, and the level of the bone remaining can act as a fulcrum point, and which also again can cause the fracture of the implant itself. So the screw loosening causes inflammation around the implant, and that'll cause some bone loss around it. And the bone loss can act as a fulcrum point for the implant to fracture at. So that's pretty much the vicious cycle. Starting from the loosening of the screw, end up in implant failure even. This one of the patient's case, he came in pretty late afternoon one day and said the implant is really loose. As you can see, the implant, although they're 2 units splinted crown, so what I had to do is I had to prepare an access opening to get to the top of the screw and kind of retighten it. So this is what happened. I made two access openings to get to the screw, and I was able to retighten it and then fill the access opening with cotton and resin. So this is what you see afterwards. Sometimes the screws get broken and remain inside the implants, but you can't get the screws out because I don't know if you can see on the right side photo, there's some whitish material inside the connection area around the broken screw, which is basically a cement. I'm pretty sure someone out there is still doing this because they want to prevent any screw loosening, right? So a lot of times what they do is they cement those screws when they're trying to tighten it down. But it it might be helpful until it breaks. But once it breaks, you can't get the remaining screws out. So that becomes even bigger problem, as in this case. So I had to grind all the broken screws out of the implant, but then I basically niched the inside, the internal thread of those implants, so I couldn't reconnect the existing prosthesis. I had to remove all two of those implants out. I was fortunate to have something called fixture removal kit. So this is pretty much to show you how the fixture removal kit works. And I was able to take those two implants out, replace it with new implants in this particular case. Okay, next, let's change gears and talk about how can we reduce the possibility of screw loosening then? How to minimize screw loosening? First one would be using stable connection, stronger connection, as we just discussed. I would probably choose internal friction fit, internal friction type connection. Second thing I can do is I can use wide diameter implants. Wide diameter, what it does with wider diameter, the end of resistance axial wall is farther away from the fulcrum point compared to narrower implant. So it's like sitting far on one end of seesaw. If you sit close to the fulcrum point or the center point, it's harder to resist to the down movement on the other side, right? So you want to sit far away from the fulcrum point. This is pretty much the same principle. Third thing you can do is try to avoid any prosthetic misfits. We've learned what prosthetic misfits can do, how those affect the joint separating forces. It'll make it worse. So try to make as accurate prosthesis as you can. The fourth factor is related to eccentric movements or cantilever movements of prosthesis. You can do one of these three things to reduce any eccentric movements of prosthesis. First thing, you can reduce cantilever force. Implants can withstand vertical forces quite good. As long as they're in line with the long axis of implant, they withstand those chewing forces pretty well. But when you move away from the application point of forces from the center, as you move away from the center, those off-axis forces increase the amount of lateral force applied to the implant. So it's quite proportional to the distance from the center axis, which means we want our implant to be located in line with the long axis of opposing dentition. We don't want it to be offset. That'll create some lateral forces. Second thing you can do is you can reduce the amount of unhealthy forces applied to the implant by reducing the occlusal table, which we have done long time ago. I guess a lot of us don't do this anymore because we've got wide diameter implants, and we are aware of the biomechanics of implants. So we don't necessarily have to reduce the table width or the occlusal table of prosthesis anymore. The last thing, you can change the cusp incline, the angulation of cusps. The steeper the cusps are, I mean, it can chew better probably, but the more interferences there are. So you want to reduce it. So if you reduce the cusp inclination 10 degree, you can approximately reduce the torque or any unhealthy forces by 30%. The crown root ratio is also important, which is also called vertical offset, not horizontal offset, vertical offset, where you can make the junction between the abutment and the implant located along the long axis of implant, like this. This, obviously you want to use the longest implant possible to make this ratio favorable. So in this particular case, this is not my case, but you could have used a little longer implant because the nerve is down there somewhere. We'll still have some space for implant, but for some reason, in this case, they've used quite short implant, so which will make quite unfavorable crown root ratio, and that'll make the screw loosening even easier. So for every 1 millimeter vertical offset, we can approximately increase the torque by 5%, which is a lot better than horizontal offset, fortunately. And you should also avoid any angulation during implant placement. If you angulate your implant 15 degrees, for example, it'll increase the torque or the unhealthy external force or the lateral component of external force by almost 80%. So you want to be really cautious about the angulation of your implant. The last thing, obviously, splinting absolutely helps, but is it still recommended these days? Probably not. So we all know we are we've been splinting these posterior implants especially a lot because by splinting it basically prohibits any rotational movements or any tipping or any uh, eccentric movements of the prosthesis. So it resists to any lateral forces better. That's why we love to splint the posterior implants uh, because it's splinted, it will not rotate. So with 3-unit implants, also pretty much the same. But what the literature says is a little different. Uh, we used to do this a lot. We used to believe posterior implants needs to be splinted because it's better that way to withstand any trim forces, but not any longer. The studies say there's not much difference between splinting and non-splinting when you're talking about 2 or 3 unit multi-unit implants. So it's no longer necessary to splint implants. We're running out of time, but let me go through this amazing health kit from Neobiotech as best as I can. What happens to fracture screw? How do we get it out? Uh, I know a lot of times in a case like this, when a broken screw is remaining inside the implant, what you do is take any instrument pretty much with a very sharp point, very sharp, long, pointy end, like an Explorer or endodontic Explorer. This point end can catch the irregular surface of the top portion of the broken screw, and it can easily rotate the screw out with counterclockwise motion. This is what happens usually. But if it doesn't work this way for some reason, we can try to use this kit called screw remover kit. Let me go through each part of this kit a little in a minute. Let me start with claw drills, something called claw drills on the left-hand side of this kit. What claw drills means, claw is this, right? Claw of wild animals. So it's got a little structure at the end of the spur. It's like a claw. So this drill is designed to catch the top surface of the broken screw, and it works pretty much the same as the Explorer or any of those hand instruments we just discussed. So you need to use this drill in very low RPM, like 50 or even slower. So let me show you how it works. When there's a broken screw remaining inside the implant, you can use this claw drill in very low RPM. You can keep rotating it counterclockwise motion. And this is how you get the screws out. This usually works like 70 to 80% of the time. But there's some cases that these won't work. So what you have to do is something called uh, other drills and something called screw remover. But before we get to the point, let me talk to you about this hand guide. These are the three different types of connection hand guides: external connection, internal connection, or even conical connection. This is basically to guide any rotary instrument inside implants without damaging the internal surface of threads or the threads. Let me show you how it works. For example, with claw drill, you try to locate this hand guide into the implant. You still have to hold it with your hands, and you can use claw drill to rotate the screw out, holding the hand guide so that it can guide the claw drill into the proper position. Let me show you this movie clip. This is hand guide, happens to be the internal connection one. There's a broken screw inside the implant. So with this hand guide in place, and you can slowly rotate the claw drill counterclockwise in very low RPM and see what happens at the end. Let me fast forward this a little bit. See, now you can use something called screw remover, which I'll explain in a minute. With the help of the screw remover, you can get the broken screw out so easily. Okay, let me talk to you about reverse drill and screw remover. This is when the claw drill does not work. So here's what we can do. This drill is to make a little notch or dent on top of the broken screw. So you have to use high RPM for this drill. So this is to make a little notch on top of the screw. And this is actually to get engaged into the notch created by the reverse drill and rotate the screw out in low RPM again. So let me show you how it works. You have to start with the reverse drill. You can see the hand guide in place. The reverse drill creates a little notch on top of the broken screw. And then with the screw remover, it can catch the broken screw and then slowly rotate the screw out. You see? And there's another guide called Perfect Guide. Compared to the hand guide, what this is different is you don't have to hold it with your hands. It can be tightened in onto the implant and still used as a guide. So this part has a thread, so which would help this guide to be seated onto the implant and gets tightened down. So this is how it works. Not like hand guide, which you have to hold it with your hands. This can be tightened down. And then the rest of the procedure is pretty much the same. You can use reverse drill to create that notch, and then screw remover to rotate the screw out. Usually for a screw remover, you don't really need any guide. So you can catch the screw and rotate it out like you just saw. One thing you should keep in mind is though, this perfect guide cannot be used when the screw broke uh, at the top part of the implant. This can be used only when the screw broke quite deep into the internal thread of the implant. So again, let me show you another example. You can see the broken screw in the implant quite deep. So the perfect guide is tightened down on the implant. You don't have to hold it with your hands. And you can see the reverse drill trying to make a little notch on the top portion of the broken screw with some irrigation, obviously. And then with the screw remover, you can get this broken screw out. This is tightening the perfect guide in its place. And reverse drill to make the notch with some irrigation to lessen the heat, obviously. And after that, you can remove the perfect guide and then start using screw remover to get the screw out. These are all in counterclockwise motion. You will see the screw out in a minute. Okay, this is pretty much the end of my presentation. I'm really sorry about what happened at the beginning of my presentation, and it's a little longer than I expected. So I can probably take any question, or I don't know if you're still there.
Okay, I appreciate Dr. Chongwa Kim about what you do about your seminar. Okay, so if you have some intention or share your clinical case to us, maybe if you just feel free to tell us or share to us. Thank you.
ถ้าคุณหมอท่านใดมีคำถามนะคะสามารถเปิดไมค์สอบถามได้เลยนะคะ I think maybe they don't have.
Okay.
Okay.
Can I show you just a couple more slides? I've heard there's some people who are experiencing quite a bit of screw loosening these days, especially last 6 months. So I was trying to figure out why that would be and trying to come up with an answer for that. I don't know if this is gonna answer their question, but let me show you an example. This is an implant on patient's lower left quadrant. As you can see, I was trying to deliver a crown like this, the zirconia crown cemented on top of stalk abutment. What happens a lot of times, especially with little experience with implants, is that does not move. There we go. I'm sorry. When the prosthesis has really strong contact, if you're not careful enough trying to adjust the contact properly, it remains very strong contact interproximally, and it won't get seated all the way down. But when you try to tighten a screw down, you think you are there because you have good friction or the good torque when you try to tighten the screw, but the prosthesis itself is not really seated all the way down. So what happens over time is the proximal contact gets loosened, so the prosthesis can now be seated even lower or even more. So that'll decrease the preload or the clamping force of the screw, so you can lose the friction of the threads, and then that's how you can get screw loosening quite easily. So you have to make sure the contact, you have a proper contact interproximally, so you can make sure the prosthesis is in its seating all the way down, or the screw is tightened down at the recommended torque, which is 30 to 35 Newton centimeters. I don't know if this helps in terms of implant crown delivery. Any more question?
Yeah, I appreciate Dr. Chongwa Kim is also prepared, like expected question about the expected question. So anybody have a question? If you have a question, just mute, cancel the mute, and then you can talk.
มีใครมีคำถามไหมคะ ถ้ามีคำถามสามารถกดอันนิ้วไมค์ได้นะคะ แล้วก็ถามได้เลยค่ะ
Okay, I think is Dr. Chongwa Kim's is your lecture is look like perfect, so I think everybody is zero understand. Okay, so okay, I appreciate Dr. Chongwa Kim to do today's seminar, and also if anybody have a question, just feel free to contact Neobiotech staff, and then we will follow up, and then if we need to ask some Dr. Chongwa Kim some comment, we ask and then answer to you guys later. Okay, today I think
ถ้าคุณหมอท่านใดมีคำถามนะคะ อยากถามหลังไมค์ก็ได้นะคะ สอบถามมาที่ทางผู้แทน Neo Biotech ก็ได้ค่ะ แล้วก็เดี๋ยวเราจะหรือมีคำถามโดยตรงกับดร. คิมก็ทิ้งคำถามไว้กับทางเซลล์ได้ค่ะ แล้วเดี๋ยวยังไงเราจะหาคำตอบมาให้นะคะค่ะวันนี้ก็ต้องขอบคุณคุณหมอทุกท่านนะคะ ที่เข้าร่วมเวบินาร์ของเราในวันนี้นะคะ and thank you Dr. Chongwa Kim for sharing your expertise and knowledge with us ค่ะ we very appreciate your time and effort thank you
Thank you very much for inviting me, having me, and I hope what I presented today helps, and hope to see you again sometime in the near future. Thank you.
โอเค
Thank you ขอบคุณครับ
ขอบคุณค่ะ
ขอบคุณครับ